We have our speakers forum, which is about to begin. All we ask is that if you have a question, please come up to the camera, because we are still broadcasting, so that way your question can be seen live and documented fully. So if you have any questions for the panel, please step over here and go ahead and ask away.
This question's for Dr. Shade. Hello.
Okay. Hello.
Can you go over your new universal gut binder and IMD? I know a little bit of why you would use IMD versus the universal gut binder in the detox protocol.
Yeah, well, I started out designing protocols for metal detox, for mercury detoxification specifically, and enterohepatic recirculation is a big part of that, especially for methylmercury. And so having a little thiol functionalized particle in there can intercept a lot of that methylmercury from enterohepatic circulation and keep it from being absorbed. But that chemistry works very well for mercury, but it may not work as well for a mold toxin, and it really has nothing to do with a volatile organic chemical or a plasticizer. So you want something to bind each of these different groups of toxins. Dr. Roundtree just ran through all of these different types of toxins that we're exposed to. And so if you're really doing a full detoxification, you need to be able to grab lots of different toxins. Not everyone will have enterohepatic uptake, but the more you bind them up, the safer the GI tract is going to be. So the new binder has charcoal, clay, chitosan. It has IMD, the thiofunctionalized silica, and a bunch of stuff to heal the gut lining. So there, in those approaches, we're trying to dump lots of different environmental toxins out at once and bind them all up with this cocktail of binders. Now, we like to start with that as a generalist detox, and then if you have a lot of mercury, we might either just add more IMD in or switch you over to something that's focusing on the thiol silica for the mercury. But it was really to just broaden out the palette of different toxins that we were affecting.
So in your detox cube, are you now including the universal binder or just the IMD? Because before we just had the IMD.
The universal binder is a great add-on. Or what we do now, we used to do levels with the cube, level 1, low dosing, level 2, intermediate, level 3, high dosing. Now I do that black box 2 with the universal binder is level 1. Clear out the general milieu of environmental toxins and then move on to the cube to focus more on mobilizing from mercury from the rest of the body. But there's a lot of ways you can always throw the ultra binder in there. You can always throw more PC, more bitters in there into the cube, and it just rounds it out more.
Okay, so you're really, for our patients doing the detox, even if their liver's showing it's functioning well, do you think we should still have them do the black box prior?
Always.
Okay, thank you.
I just wanted to share with the audience a study that was published by Dr. Roger Masters, an emeritus professor at Dartmouth University, and I can't remember exactly what it was, the numbers specifically, but it was over 400,000 children that he studied, and he looked at their whole blood lead level, their IQ, and whether they were drinking fluoridated water from a municipal water source. And he concluded that drinking fluoridated water in Caucasians increased the toxicity of lead by a factor of 4-fold. In Hispanics, it was 6-fold, and in blacks, it was 7-fold.
So fluorine and lead is a good combination?
Any more questions?
Can I ask a question? I'll ask a question while he's coming forward. Dr. Ashner, is the next step in researching NRF2 upregulation to research what blends of toxins, as we were talking about with pesticides, might have, for instance, mold toxins are said to inhibit NRF2. So if you inhibit that, then you have like a skin one knockout. Finding out what toxins inhibit as well as which ones upregulate, so we can look at different pairs of things that might be really synergistically toxic.
Yeah, it's a very good question, and actually you might interfere, or you can interfere with NRF2 signaling at multiple levels. You can make less NRF2. You can, if you have a SNP, or we don't have luckily any complete knockouts in individuals, but you can make less. And there's also important things in terms of the transport of NRF2. Actually, I showed it in my talk. NRF2 can freely move from the nucleus to the cytoplasm and vice versa. And there are different molecules actually that regulate this movement into the nucleus and outside of the nucleus. For example, FYN, F-Y-N, is known to trigger the exit of NRF2 from the nucleus into the cytoplasm, so you basically shut down the response. I had a graduate student that very recently showed that mercury actually affects FYN. So with very low exposures, and this comes back to the hormesis, actually the FYN makes sure that the mercury or the NRF2 stays within the nucleus, because what you want to do is to upregulate the NRF2 response. But she has also shown that with high levels of mercury, you get the opposite effect. The mercury basically causes the FYN to move very quickly out of the nucleus along with the NRF2, and then you don't get any antioxidant response, and the effect of mercury is much more severe. So the short answer to your question is that it's not just how much NRF2 you make, it's also where the NRF2 is and what different components of this signaling pathway are being affected. It's not just the NRF2 itself, it's a FYN. There's other transcription components that are known to affect NRF2 regulation, SARC, and others. So it's a very complex story, and I think we're just getting basically some insight now as to how mercury might affect that.
Yeah. And one question as it goes down there, I saw you had methylmercury kind of hormetically upregulating NRF2. Did you look at inorganic? Does that do it? Same thing.
So it's known that certain types of cancer cells have constitutively upregulated NRF2. And so some people are saying, boy, in that scenario, you shouldn't use anything that's going to activate NRF2 at all, which I'm not sure how you would do that, but I'm just wondering your response to that concern. In other words, if you got cancer, don't eat broccoli. That's really the kind of, I think that's absurd, but that's, some people are taking it to that level. So I'm curious.
One of the side effects of the cancer is high levels of reactive oxygen species. So the more NRF2 and the more intact the response, the better off you are. My short response.
I want to thank each of you for being here. Thank you very much. I have a question for Dr. Gabb. I've been treating obstructive sleep apnea for some time, and I'm really interested in your appliance, your ACG, HERS, and where you have them made.
So there's a lab in Pleasanton, California, Prosomnus, and they're milled devices. And there's a gentleman, Jerry Vogel, in the back of the room. He could give you some information and maybe show you what one looks like. Prosomnus is the lab. Yes, and it's the HERS.
What are the 5 states that still won't let you do a home sleep study on your dental patients?
New Jersey, it's a felony. Texas, Georgia, and I don't know the 2 others.
I'm in Montana.
You're probably okay in Montana. A dentist can't give a sleep study out. It's ridiculous, but that's the way it is. You can go to jail.
Oh, to discuss the levels of these toxins in ancient people. I have an article here in New England Journal of Medicine, 79, skeletal concentrations of lead in ancient Peruvians buried 1,600 years ago were compared to English and Americans, we have 700-fold higher than these Peruvians did. I think that says a lot.
Wow.
What kind of cars did they drive?
Campbell cars, fuel cars. Anyway, for those of you on the panel that can answer this, I'd like to get an opinion on if we were going to choose 3 nutrients to minimize the body effect from removing amalgams, what would be those 3 nutrients that you would choose?
To minimize the effect on the body when you remove amalgam?
So biological support of the body.
After mobilization, I think he's saying.
Well, during removal, right?
Mobilization process.
Yep. Let's say pre and
Yeah.
post.
I'll put mine in glutathione, milk thistle, and I'd probably do lipoic acid.
And why not NAC? Can I ask you? What?
Oh, like NAC. Well, the question is NAC versus glutathione. So NAC, the glutathione precursor, or directly glutathione. And you can evaluate, I mean, NAC is going to be cheaper if all of their upregulation or if all their synthesis of glutathione is fine, then that's fine. If they're a little compromised, then going right to glutathione would be the thing. But lipoic acid then is that's my most reliable NRF2 upregulator. So that's why I go for that.
I don't do amalgam, so.
I would suggest, first of all, vitamin C, because through the Meister cycle, you generate NAD that causes the oxidized glutathione in the cell already to become reduced, and you could build it up on the inside, because I don't think you can get the nutrients inside the cell effectively to make to increase glutathione. The second thing would be lipoic acid, because lipoic acid is a major energy driver. It's primarily inhibited by the mercury you've been exposed to, and it provides a pyruvate for the electron transport of the TCA cycle to make NAD inside. So those would be the top 2 that I would come up with that won't do any damage, and you need to replace them if you're mercury toxic.
Do you think it matters if it's R lipoic? Do you think it matters if it's R lipoic or the racemic? And what kind of doses do you use?
I don't treat patients. I just know the biochemistry. No, it has to be L-lipoic. It has to be the natural lipoic acid.
Okay.
You're trying to replace what's been taken out, because mercury binds to lipoic acid and would take it out of the system and make it toxic if it stayed in. So.
And Dr. Ashner brought up a lot of work with NAD, and we've been doing a lot of work on getting NAD delivered in various forms. And that brings up another question that I wanted to ask him, and I think it would be a fantastic supplement to take during that, as long as you can get it in. Like there's the nicotinamide riboside that's out there. There's straight NAD. None of those are really good absorbed. We are working on nanoparticles of those. But I'm assuming that the reason that worked as a preventative is that it was turning up ATP generation, that was turning the wheels of all of the creation of glutathione, creation of the enzymes, creation of the transporters to move it out of the cells. Is that concurrent with your thoughts?
Yeah, we haven't measured. We measured glutathione. We haven't measured some of the other compound that you've just mentioned, but that's correct.
I have a question regarding NAC and what the advantage of taking NAC is over taking cysteine. Cysteine crosses the blood-brain barrier handily, and to get the 1,000 milligram equivalent of cysteine, you'd have to take 1,500 milligrams of NAC. So I'm not sure why we're doing that. And the question regarding the glutathione is, since cysteine is the rate-limiting nutrient for making glutathione, it's a lot cheaper to take NAC or take cysteine to increase glutathione production, I would think then it would be to take liposomal glutathione, which is a lot more expensive. And thirdly, in the question is some cancer cells actually repair themselves by using glutathione, and how can we identify who those patients may be, because you wouldn't want to be giving high doses of cysteine to those individuals.
Yeah, the cysteine versus NAC. What I thought was going on is that NAC is better absorbed than cysteine. You're saying that cysteine gets across the blood-brain barrier better?
That's what things I've read have indicated that.
I thought the acetylation actually enhanced absorption. It was my understanding that acetylation, in acetylcysteine actually enhances absorption, that it's analogous to using L-carnitine versus acetyl L-carnitine, that acetyl L-carnitine is taken up much more readily. And I also think that I'd read that L-cysteine has poor GI tolerance, that people get more nauseated from it. I mean, I know that, when you have acetaminophen poisoning, you're using 35, 40 grams of N-acetylcysteine, and there's some reason they don't use L-cysteine for that.
Cysteine can be irritating, but it can be, if you take it with food and don't take it in the morning, most people tolerate it perfectly fine.
John, I think there was a publication out showing that comparing cysteine to N-acetylcysteine for the production of glutathione in the cell system, that the N-acetylcysteine causes more glutathione, a higher glutathione level.
I think that's why people use it. Yeah, and I think that was why it caught on. And it was so long ago since I read that stuff that I haven't really tracked it so well. But I'm happy to go back and look in there. Your other questions about NAC versus glutathione. And I said when people are compromised in their ability to synthesize glutathione, then if you make a liposome right and you can get it in there, then it should be a better way to get those glutathione levels up. And you can point to the studies that were done, I think it was done with Redizorb, and they were taking immune cells from HIV patients and challenging them with pneumonia. And to get them to react to and kill the pneumonia cultures, they needed to get the reduced glutathione levels up to a sufficient level. And they incubated them with either liposomal glutathione or NAC. And they needed a 5,000-fold higher dose of NAC to drive the glutathione levels up than the glutathione in the liposome. So, where is somebody going to be deficient in synthesis if they have viral disorders? I believe that in cases of mold toxicity, there's inhibition of some of these enzymes. Perhaps Dr. Ashner knows others. And before I hand it to him, the question on cancer and glutathione. So Dr. Ashner just said, in cancer, there's a lot of upregulation of ROS, and with that is going to come upregulation of NRF2. There can be more glutathione in there, and that may just be a consequence of their metabolism. Now, glutathione is also correcting TH1, TH2 balance, and the TH1 activity is essential for being able to kill cancer cells. I believe I haven't read the paper, but there was some work done I think related to Redizorb or related to Tim Guilford, where the results suggested that the effects on TH1 were more important than any perceived effects on rescuing a cancer cell from oxidative stress as a result of using the glutathione for their own advantage.
If one were to expand the list higher than just 3, where would selenium fall? Would that be further down like 10, or would that be up in the 4 or 5 area?
Before I hand this off to anyone else, I would generally put it up there. In fact, I think in our amalgam protection protocol, we have some selenium in there. Though I was just lecturing in Austria, and these Germans have been studying this forever, and there was the Max Donderer guy, and he did all this research on selenium, and he claimed that selenium, as it's going through its cycles, and for a little bit it's hydrogen selenide, and it's got just infinite ability to bind to mercury, and they found these mercury selenide crystals locking mercury into different parts of the body, and they thought that it was a really bad thing. It kind of threw me for a loop because I wasn't really expecting that. My normal take on selenium is that because mercury, when the selenium runs through the hydrogen selenide form, or when it's as a selenol in like thyroidoxin reductase, it has high binding for mercury. Mercury sticks to it, knocks out that enzyme, and you need to resupply selenium so that you can remake things like glutathione peroxidase, thyroidoxin reductase. These are key elements of your free radical defense. And when you look at the studies on selenium and mercury interactions, and they were kind of sold that selenium protects you against mercury toxicity. But it's really when you're deficient in selenium, subnutritional levels of selenium, you're more exquisitely receptive to mercury toxicity. And as you replete the levels, you get up to nutritional sufficiency, you get more and more, let's call it normotoxic. You have a normal toxic response. And when you go beyond that, you typically don't get more effect until you go so high that the selenium's moderately toxic and becomes an NRF2 upregulator. So I hope that was confusing.
I can't thank you guys enough for coming here and giving us your stuff. My question is, when I was 14 years old, I suffered with left temporal seizures. I had 30 surfaces of amalgam, chewed gum, competed as a gymnast, very low body fat. With that susceptibility, is it because of the amount heading for the brain? 20 years, I was on Depakote and Tegretol. I saw a cosmetic dentist after dental school, got it all out, and it went away. So what's your theory? What do you think? What was happening? Is it something idiopathic? Or is it something that was really creating the seizures? Similar to autism, where 30% of those with autism also have grand mal seizures. Thoughts?
I guess you could identify me as the mainstream environmental health, environmental epidemiology person. As far as I've been on a number of different expert panel reviews to look at mercury, as well as looking at the potential environmental etiology of autism. I guess at this point, all I can say is that it's like connect the dots. There's lots of dots, some patterns emerging, but not enough to hang your hat on. And what we would like to see is, unsurprisingly, more research dollars to really figure it out. One of the things that we actually talked about when we were just, hanging around coffee and whatever, was that there's these communities of toxicologists, environmental health folks, epidemiologists, who don't really talk with each other that much. And unfortunately, it leaves big gaps between what we think may be important in our discipline, but what might actually be, from a very holistic point of view, the most important kind of gaps that need to be addressed with good science that's kind of interdisciplinary. As someone who sat on the National Environmental Council for NIH's, the National Institute of Environmental Sciences, for 6 years, I can vouch for those gaps being huge, and we have a lot better job to do to try to knit together our communities to figure out how to work together better to answer these big questions. I know that doesn't really answer your question that well, but that's the best I can do.
So here, let me give you a second stage now. Now that you haven't really had an answer, and that's fine. So as a person that had it in the mouth, now as a provider that is exposed to it every day. So we will go a 20-year gap from age 33 to 53. Not a seizure, nothing. It comes back with 1 grand mal at age 53. So now I look at my week of working that week, and I had taken out 30 silver fillings because I stopped using amalgam in 95. So that's when I started looking, and that's how I got in this group. And I started wearing the mask. And I didn't have a seizure since. So again, I think it just confirms my theory that there has to be a direct correlation with the mercury invading the brain and leading to some type of hyperactivity that's leading to the seizure activity. And I believe that's what's happening in autism. And that's why 30% of the kids that have autism also suffer from grand mal seizures. So I think there's a correlation there. Something's creating the hyperactivity that's putting the brain into the protective mode. So there's my thoughts.
Yeah, I don't think anybody doubts the relationship between your mercury exposure and your seizures, but we're kind of here to connect the dots between them mechanistically, and we don't know on that. I mean, there's a lot that goes on up there. It's not classic, like, how many dentists in here have had mercury toxicity? Most of them got here through, raise your hand, and raise your hand now if seizures are part of that. And then we could go through all the different things, and everybody has their little way that their neurochemistry broke down. And maybe there's infections along with it. It's just hard. That's not as straightforward, like, oh yeah, that's how that happens.
Right. So would you take your detox program then to make sure that I'm as clean as possible?
Yeah, I do whatever you can to upregulate your own natural defenses, and always be flushing, always be clearing, and of course minimize exposure.
Thank you.
Thank you all, panel there, for your expertise. Just a quick little question on cilantro. I recently had a naturopath refer me a patient for the safe mercury removal, and her only suggestion to the patient was that she wanted her to take cilantro.
Yeah, cilantro and chlorella was that, it's funny because I talk about mobilizing and binding, and that was always their go-to, was that cilantro moves the mercury and then chlorella binds it. Now, I can tell you why chlorella binds it, but I can't tell you anything about cilantro because nobody has studied cilantro. Nobody knows what the active molecule is. They don't know what gene sets they're upregulating, what enzymes they're upregulating. You can see that something happens, but nobody knows why. So when I developed my systems, I had to be able to use nutrients and phytonutrients and different chemicals that there was a body of literature around, and I could say, well, reliably we know that this upregulates NRF2, this does that, that does that. And so I never used cilantro because I didn't know what it did. And then how do you standardize the dosing? Nobody knows. But it was used for a long time, especially in the Klinghardt camps. Klinghardt Nomura, the Japanese guy.
I know the naturopath doesn't work with any heavy metal detox. She doesn't have a regimen for that. So the patient was asking me, like, how much cilantro do I take? When do I start taking it? And I was like, well, that's something you're going to have to check with her on. So I think I can probably just suggest your top 3 picks, or maybe some selenium in there too.
Yeah, it'd be good to go with somebody's protocol that's been worked out. And most good protocols, they start low and they work up high, and you can always fit your tolerance into that dosing. But it's good to go with, some combination that people have done and they've worked through enough patients and they've seen that this protocol works. And, that's
So in your
based
opinion,
on someone's success.
Have you read Dr. Amur's paper where he showed cilantro?
no.
You should read it.
Dr. Moore?
Well, he showed it. Well, that it moved mercury from the brain. If you believe that, I'd like to sell you some land in Florida. You can't say somebody had a good result just because he claimed he did. Because I sat beside him and I asked him one time, "How did you do this?" And he used his fingers on his head, and he would do that on his food before he ate it. The rest of us don't have that kind of power. I don't want to question another person's religion, but I'm not going to fund it. Oh, I'm just saying, I don't believe it at all. You're asking these guys how this works, and I tell you, I doubt it does.
Well, I didn't think it did either, just cilantro alone, so I just want some feedback.
I want to tell one other story. When I first got in with this group, we had a guy come to a conference that I held, and he was talking about how chlorella took all the mercury out of his body, that whenever he took a dose of chlorella, he could see his urinary mercury levels go way up, because he could measure them. He was a mass spectrometrist. And he came in and he gave his data. I let him talk for 10 minutes. And I flat told him, if you had that much mercury in your body, you'd be dead. Where's your chlorella? And we tested his chlorella. There's a trick. It's not a trick. It's chemistry. You add tin chloride to something containing inorganic mercury, or Hg2+. It'll convert to a vapor, and you can measure it with a mercury vapor sniffer. We took the chlorella that this guy was taking to remove mercury from his body, dosed it with 10 mLs of tin chloride, and took the mercury vapor sniffer, and it pegged it. So this guy was seeing mercury in his urine when he took chlorella, because the chlorella is used to treat land to bind to mercury. But that doesn't mean it comes into your body and takes mercury out of your body. And so I have a lot of serious doubts about chlorella. May be a good food. I would say that it probably is a decent food to eat, but I wouldn't say that it binds mercury and takes mercury out of your body. I haven't seen anything that would convince me.
But I did binding studies on it, just ground it up and did it. I do it with like seawater strength chloride, just so it has something to fight against. And it has some strong binding groups. They look like thiol groups. There's just not a lot of them. And that was why we made a stronger one. And so when you look at something like methylmercury that has a strong enterohepatic cycle, that has been shown, as far back as 1973, that thiol binders will interrupt that and drain down the levels faster. And so that's why they did it. But then you got this stuff that's toxic, and that's why I said, I know why chlorella works. You just need a ton of it. But the cilantro, we just don't.
I would believe that chlorella would take mercury out of your gut if you were eating it. It picks it out of dirt. But that doesn't mean it crosses the intestines and goes into your peripheral tissue and does it. That's the thing I'm saying is not worthwhile. And so when you try to come up with a treatment, make sure that the research you're quoting is based on something solid and not woo-woo medicine.
Well, I think if anybody else has any more questions, you can thank our panel and our great speakers for today, and may we see you again at another Academy meeting.